Now you get to ask all of your social determinants questions. I am going to turn things over to Ian Morrison. He has the fabulous job title of being a futurist. I wish I had such a cool title. Ian, take it away.
Thanks, Cece. Well, great, and what a great panel. As Cece mentioned, I'm a futurist. I often say that the future of healthcare only exists on PowerPoint. We never actually do anything. We go to meetings about it and present it, And so there was a wee bit of that in that panel as Cece was trying to point to. Whatever happened to value? I mean, I've done like 10 board retreats this year with hospitals, and I keep saying we're moving from volume to volume because everything I hear is, about utilization in beds. So I think let's finish the value thing before we go on to the social determinants. But anyway, that's a little editorial. So we have a fantastic panel here, and let me just introduce them quickly, and then I'll do a little bit of what Cece did with a little bit of a warm-up. To my immediate left is Martin Otto, who is current board of director member and former chairman of the National Association of Chain Drugstores. His day job is Chief Operating Officer of HEB, a major retailer in the southwest of the country. To his left is Dr. Akram Boutros, who's President and Chief Executive Officer of MetroHealth in Ohio. To his left is Dr. Will Schrank, who's the Chief Medical Officer of UPMC Health Plan. And to my far left is Dr. Hal Patz, who is Executive Vice President and Chief Medical Officer of Aetna. So a very distinguished group. Welcome all. And let me just start by saying that the social determinants of health thing is getting a lot of attention, as evidenced by the very thoughtful questions you already provided. It's not a new thing, right? We've known, and certainly I trained with Bob Evans, the Canadian health economist, who was the sort of father, one would argue, of reinventing or reigniting interest in social determinants in the 1990s. But it goes all the way back to the Whitehall studies in the UK, where popularized by Sir Michael Marmot, which basically showed that even in a nationalized health system, and even if you adjust for behaviors, it's good to be at the top of the food chain rather than the bottom of the food chain. Looking at death rates in the civil service in Britain in the 60s. And Evans and his colleagues in Canada did very similar work in pulling together a multidisciplinary group under the auspices of the Canadian Institute of Advanced Research, and produced a book in 1992 called Why Are Some People Healthy and Others Not? And the short answer is the single biggest determining factor behind health is income, right? If you actually look at the more recent studies we've seen at both Angus Deacon's work at Princeton and the Harvard and Stanford studies on life expectancy in the US, it is a perfect correlate of income. So we know that income and other aspects associated with income and education have a huge impact on health status. And it's true in other countries, there are big disparities in outcomes by income. So why are we suddenly interested here in the US? Because that all smells a wee bit like socialism. I say to my kids all the time, be in the top 1%, you'll do just fine, right? But that's a nice thing to say, but that's not quite actionable if you think about it. So we're not in a world where we're about to massively redistribute income. We just passed a tax bill that went the other way, right? So why are people interested in social determinants all of a sudden in the US? And there is real interest. In my travels across the country, we're seeing it from health plans. You've heard it from hospital leaders. You've heard it from philanthropists, from the business community. And so it's a real deal, and that's what we're going to try and probe. And I do believe in the American context, we have to find a way to make social determinants actionable. Not just talk about it and put it on PowerPoint slides, but actually do it. And it will require the help of all the stakeholders we have represented here. And I think there's lots of valid reasons why we're more interested today than we have been. And you heard from our previous panel, whether it be the shift to risk, whether it be the rising burden of chronic care, whether it be research evidence of causal factors and the social determinants that affect behavior. So there's lots of legitimate reasons why we should be interested, but the focus of this panel is really, okay, how do we make it actionable, and how do we make it actionable by collaborating? So I'm really excited to hear from our leaders here, and let me just give each of them 2 or 3 minutes to sort of explain how they came to this panel in terms of their interest in social determinants and what role their organization plays in this sort of emerging field of interest. And perhaps I can start with you, Martin.
Sure. Thank you, Ian. I'm here in 3 capacities. One is as a payer, and I'll explain briefly about HEB in a moment. And secondly, and a payer, by the way, who's very frustrated with the lack of progress on the topics that you're speaking to. The second is that we're a pharmacy operator, and so we have some role in healthcare in that sense, both at HEB and also with my role at NACDS. And then thirdly, is a very concerned citizen, because what we're leaving our kids isn't going to be pretty if we don't quickly collaborate and act on this. This HEB, by the way, we have about 100,000 employees. We're in Texas and in Mexico. We're self-insured, and for that reason, I'm very concerned about the whole topic of healthcare and its cost. The topic today is social determinants of health. The thing that I've been focused on is the determinant of the social determinants of health, which is the high cost of our system, which creates so many of the problems. And what I'll do is I'll walk through quickly the vicious socioeconomic cycle that we're in. As a nation, we're spending $3.3 trillion on health care. That's 18% of our GDP. In contrast to other countries in Western Europe and other developed areas, they're at 10 to 12%. So we're spending $1 trillion in excess of what we ought to be if we were to be competitive with these other nations. The additional issue there is that our outcomes are poor by any measure. Life expectancy is very short compared to other countries. Infant mortality is very high. The incidence of diabetes and obesity is high. The number of chronic conditions suffered by the elderly here is higher than in other nations. And so we're spending a ton of money, and we're not getting the kind of outcomes that we ought to be hoping for. Additionally, our access isn't good, as everybody here knows. We've got 30 million uninsured Americans and another 80 million who are effectively under or uninsured because they're on these high deductible health plans. And so it's really not a pretty picture by any measure. And so that's the starting point, is what we're spending on health care, which I think is the linchpin. The knock-on effect then is that money that we're spending on health care cannot go to social services, which results in part in the high poverty rates that were spoken to in the first conversation today. Poverty, in turn, breeds education. The highest correlation between education and educational results is income level and poverty. Where there's high poverty, there's poor education. Where there's low poverty, there's good education. It's about that straightforward. The secondary factor is teacher pay relative to the rest of the population in the area. So both of those things matter. We're not spending enough on poverty-related topics because we're spending it all on health care, and additionally, we're not spending what we ought to be on education. And so these two things, being what they are, breed more poverty and more poor education, which in turn breeds poor health outcomes, which in turn breeds more healthcare spending. And so this cycle has got to stop. And the reason I'm here is hopefully to play some role in a conversation to achieve that end. And that's my comments for now, and then I know you'll have more questions.
Great, Martin, terrific. Akram, could you give us your perspective? Because it's a very interesting situation you're in the organization you lead.
MetroHealth is the public health system in Cleveland, Ohio. We operate in the same town as Cleveland Clinic and University Hospitals. And I hope you didn't hear me say compete, because it's really hard to compete with Cleveland Clinic and University Hospitals. So as a public health system, right? So in 2010, 8 years ago, MetroHealth found itself having 22% of the patients were non-paying patients, so provided free care for 22% of the patients, and 39% of the patients were on Medicaid. So 61% of everyone we took care of was uninsured or underinsured. So we were going out of business. So we had to figure out very quickly how to provide better healthcare at significantly lower cost. That's when we began our entree into thinking about what are the underlying determinants for these poor health outcomes. And we delivered in a model that was 100% employed physicians and ended up actually achieving some pretty remarkable breakthroughs. We collaborated with a lot of agencies, everybody from legal aid to the food bank to other folks. And in 2013, when I came to MetroHealth, we tried a really bold experiments that demonstrated that we can achieve, by addressing some very basic issues, from transportation to housing to other upstream issues, some significant improvements in outcome and reduction in costs. We did an 1115 Medicaid waiver for about 30,000 people, and in 1 year came in 30% below the Medicaid benchmark. So that is the idea of having a narrow network coupled with addressing the social determinants of health. We're able to achieve that. Since 2013, MetroHealth has gone from about 5% of our population being at risk contracts to today 50% of our patients. So from 5 to 50% of the patients now in at risk contracts. And we've learned what are the things that actually work in providing better health care and reducing inpatient utilization.
Yeah, that's terrific. Well, can you say a little bit about, from your perspective, what social determinants mean from UPMC Health's perspective?
Sure. So just to echo how you introduced the topic, everyone's talking about social determinants of health. I participated in a discussion a couple weeks ago that was actually led by C.C. Connolly, the Association of Community Health Plans, where most of those health plans, they're varying in size, they're varying in sort of their focus, but largely they have a payer and a provider and take a great deal of risk around managing a population. And activities around promoting or addressing social determinants of health are table stakes. It's not a question of, hey, well, we're doing something on housing, we're doing something on food insecurity, we're doing something on transportation. Everybody's doing it all. Because if you're taking risk and you're deeply engaged in a community, you're crazy not to look hard at how social context is impacting the health and the healthcare costs of the population you serve. So it is decidedly reassuring. There's a handful of barriers that still exist, and some of the things that we're working on here, we're working on at UPMC to try to foster a sort of more rapid adoption are around data and around evidence creation. So in the area of data, these are vulnerable folks that we're trying to address, that we're trying to help. And capturing the right information from our vulnerable members, our vulnerable patients, can be challenging. And it's generally captured in an unstructured kind of way. And we're making a real big effort to create a registry for social determinants of health, where we use different kinds of technology, natural language processing, to capture information from electronic medical records, from unstructured notes, from care manager communications, to try to really enrich our understanding of the social determinant challenges that our members face. Maybe more importantly is we lack we lack the evidence that we need about what are the right programs, the right interventions. Where do you get the biggest bang for your buck? How do you really target the right intervention to the right patient? We have a good laboratory now. In Pennsylvania, there's a new program, a managed long-term support services. Our product is called Community Health Choices. There are 3 managed care organizations that are responsible for managed long-term support services, largely the social services for the most complex members of the state. And those products are integrated with our duals medical cost management program. So we're able to work hard to test and learn how interventions to address social determinants ultimately create value on the medical, healthcare cost side. But I would say, despite those barriers, we're seeing just incredible momentum, in the marketplace, in a setting where we're moving towards more risk and deeper value-based payments. We are increasingly partnering with virtually everybody out there. We're partnering with retail pharmacy. We're partnering with urgent care. We're partnering with a whole host of community-based organizations to better manage our patient population. In that setting, there's so many opportunities for us to integrate data, mission, and really work together to drive improvements in patient social determinants or their social context of health. And I think all of us hope that a couple of years from now, we're not talking about social determinants as this fringe thing. It's a central part of healthcare, like managing, like care management, like prevention, like addressing the social context that our members experience is at the very center of what we do.
Well said. So Hal, you've been on the provider side, a distinguished physician, been in the academic setting, you're now Chief Medical Officer of Aetna. How do you come to this conversation of social determinants, and where are you headed with this?
Thank you, Ian. Yeah, so until about almost 4 years ago, I was CEO of a large health system in Pennsylvania and Dean of a College of Medicine. And at the time, Aetna was looking for a clinician who could help develop a clinical strategy to guide its corporate strategy, which is currently underway. And the goal was to move a health insurance company to become a health company and then a healthcare company. And the focus really is about leveraging multiple determinants of health. And as I think been discussed now several times, healthcare per se attributes to about 10% of your health status. And we know that genetics is extraordinarily important, 30% of your health status. Do you die a premature death? How do you rate your own health, your own well-being? Can you achieve your aspirations for better health, which is different for each individual? And then, of course, the environment, 5%, which is not insignificant if you live in a place like Flint, Michigan. And then we're left with 60%. Now, people talk about social determinants of health, but often they're really referring to behavioral determinants of health. Behavioral determinants of health are about 40% of your health status, and the remaining 15% are the social determinants of health. Lack of education, poverty, as you described, living in a community with a food desert, being exposed to violence and crime, not having a sidewalk to walk out on the street and even get exercise. These are extraordinarily important. And the irony in the whole thing is we spend over $3 trillion on healthcare, which attributes to 10% of your health status, and we know that a third of that, it's been shown repeatedly, goes to total waste in the system. 60% of that is administrative waste, 40% is clinical waste. That's more than we spend on education each year in this country. It's extraordinary. When you look at the United States compared to other OECD nations, we are highest per capita in healthcare spending, but compared to many of those countries, when you look at social spending and healthcare spending, we're around 14th. France, which usually tops the list, spends 45% of its GDP on social services and healthcare. The US combined spends about 35%, and the difference is most of those Northern European countries spend 2/3 on social services and 1/3 on healthcare. We spend about 50-50. So as I was thinking about this, and we spent about almost 10 years in Pennsylvania thinking about population health, what you've described as the second curve, Ian, how you create scale, how you engage in a population, but still a lot of that, quite honestly, was hospital-focused and clinic-focused, thinking about this transformation at Aetna and how we could move to what I've called this third curve of personalized health. How can you engage individuals to allow them to achieve their aspirations for better health? What they define as their better health by leveraging not just healthcare, but all 5 of those determinants of health, of which the social and behavioral determinants become extraordinarily important. And it's really through 3 pillars that have to coexist, I believe, to do this effectively. One is the interoperability of solutions, be they in the home or in an urgent care center like a mini clinic, or in a doctor's office, or if all other systems fail, in a hospital bed. But to do it in a way that is interoperable and actionable by the patient. Today we have this paternalistic system, and I say this is a practicing physician, where it's the doctor that owns your own health, your health information, or the hospital. Why don't you own your own health information and own it in ways where you can understand what it means, not your BUN is 50, but understand what it means and then act on it? That all of a sudden flips the entire paradigm to a personalized system as opposed to one that is rather historic and paternalistic. So that's number one. Number two is engagement. We've built exquisite systems, but we don't often connect the last 10 feet of cable into the home. How can we do that? We can do it for healthy people digitally or through telehealth, and for medically complex, the chronically ill that have a huge health burden, by having social workers or nurses or other health workers literally going in the home and engaging. And last but not least, as the earlier session discussed, in the third pillar, to have shared risk. Many of our members with $10,000 deductibles have enormous financial risk. Their employers, the government, state government, has enormous financial risk. We need to make sure that everybody in that ecosystem has risk, and we've developed an array of value-based contracts with providers, with pharmaceutical companies, and even with device companies to create that ecosystem of shared risk. So that's the model, that's where we're going, and it's really at the end, measuring it. We just announced 2 weeks ago our well-being assessment that really gets at the heart of this. Because if you can't measure this, if an individual can't measure it for themselves, and those participating in the ecosystem can't measure it, it's hard to know where you're going if you don't know where you are. So in this well-being assessment, we're partnering with Chen, Harvard School of Public Health. There are 6 domains, and this really gets back to the social and behavioral determinants of health. It's about purpose, character, as you said a moment ago, financial status, emotional status, connectedness, and physical health. Those 6 domains together, I think, give us a view as individuals of where we are, and give those that we work with and support us the opportunity to engage us in ways that are truly meaningful.
Yeah, that's great. So I mean, Martin started us off with a really elegant framing of this crowding out problem, right? You know, that healthcare sucks up all the energy. We can't get to that virtuous cycle of higher incomes and better education. We've identified, I think, each of you, the importance of risk as a motivator, but I don't think we're saying you have to be at risk to care, right? But it certainly helps, right, if you're at risk for the population. I want to sort of drill down a little bit in terms of what's working and what's not. Because, Will, you raised a very important point that I've heard from other experts in the field, which is, do we really know what works, right? And how do we intervene? And, you know, I'm always encouraged when I hear, Akram, you know, examples like yours where we did it and we got a 30% reduction. I mean, I've been working with my friends at ProMedica in Toledo who are, I think, you know, doing a lot of important things, including a social determinant of health screening on every single patient that they encounter and linking that back to EPIC. And have made a lot of investments in terms of trying to follow the consequences of that and measure the pilots and the people that are. So I guess my first question really to each of you is, what is it that's working that we can say, if somebody out there is actually going to go after this, we agree there's a lot of energy. What is working, in your opinion, the best to actually move the needle? Martin, why don't we start with you?
Sure. I'll start with a little bit of what we're doing. And the way I'd frame this up is what are the things that we can do on our own? And then within that, what's easy and what's hard? And then secondly, what can we not do on our own as a payer?
Right.
And in terms of what we can do on our own, our team has created now 2 clinics that are for our employees only at this point. And the point in doing that is to create coordinated care for our patients, and then secondly, to provide care in the field for patients that have high-cost issues or chronic conditions that require more intensive help. And we're early in this, but what we're finding and what we're doing with the clinics is instead of having the average 15-minute appointment, and I'm no physician, you guys are, so you'll know more about this than I do. Instead of having the average 15-minute appointment, our appointments are 30 minutes. And by providing that time, we're finding that issues are being detected that previously hadn't been, and we are beginning to see progress also on some of the biometrics and also the satisfaction that our employee patients feel. By having the coordinated care, we're also finding that we're able to have the patients be then referred to hospitals and specialists who are like-minded in terms of not providing redundant procedures and doing this in a way where we can manage the price per event in a better way. And so it's too soon to call it a success, but it's something that we're doing and we have some hope there. And the goal there is that as a payer, candidly, we have not felt as involved in the process as we would like to be and think we ought to be, and this is one step toward getting there.
Right. No, that's very important. In fact, we had a session yesterday. We heard from our colleagues at Rosen, who are hotel operators and resort operators in Florida, but very much similar story of saying, hey, let's take control of this. Let's look at where the money flow is, and let's try and work upstream to get rid of the things that are exacerbating folks' health. Akram, say a little bit more about what the actionable steps. I mean, you're in a unique situation. I'm on the board of the Martin Luther King Hospital in Los Angeles, which is, I think, a great success story of coming back from the dead. But we're very much focused on population health. We're 97% not commercial, right? And so we have to think about going upstream. Is it in the case of your interventions, necessity is the mother of invention, or and what? In terms of specific programs, what do you think are the bright lights that people should take and maybe be actionable even in a different context, more conventional health system context?
So I would say definitely necessity is the mother of invention. I don't think anybody in healthcare would run towards social determinants if it wasn't for the risk component of so we at MetroHealth, when 60% of your population is significantly underpaid, unless you address it, you're going out of business. So we're able to do bold things because we knew we had a burning platform. Second, I would say to you, in healthcare and health system delivery, unambiguous, highly committed leadership is really important. So the CEO not saying both volume and value are important, are really critically important. So what we said is we're making this transition. We may lose money during the process, but we're going to reduce admissions, readmissions to the hospitals and admissions to the organization, and we'll figure out how to make it up in other ways. So we reduced our readmission rate by 2,000 patients a year. That's $32 million for us on average, and our CFO was not working counter to that by talking and saying we need the volumes, and our chief operating officer. So this really big commitment and telling providers this is our goal. It really is incredibly critical, and this is nothing you haven't heard before. But I would say to you, it is patient engagement that is critical, because you may design program for any population and every patient is a little bit different. So once you engage with the patient, it is not very difficult to solve some of the underlying problems. So one of the things that worked incredibly well for us is medical legal partnership that has 4 legal aid attorneys that we pay for that are sitting in our clinics that are solving problems for the patients. A transportation system that costs MetroHealth $3 million a year of picking up low-income patients and bringing them to the hospital and the clinics and having them being cared for. It's not available to everybody, but some folks actually need it. So that's why saying about engagement. And last, and absolutely critically important, is having standardized treatment protocols and care protocols. Without them, you can't tell where you're failing and where you're succeeding. So for us, having 100% employed providers in our health system, we're able to look at that and actually work at both ends of the curve, having the folks who are providing better care, better quality care at significantly lower cost, mentor those who are not. And I'll tell you this from a big data perspective, we ignore the middle. There's not a lot of areas for you to fix in the middle. We look at those outliers, both positive and negative outliers, social sciences, positive deviance and negative deviance. We compare them. We learn a great deal by that contrast for each and every patient, and we work towards it. But it is really an individual effort on every single patient to solve their specific issue. And the tools already exist.
Right, and that's a very important point. I think you answered a question we were going to get to, but it's certainly, these are not separate things, engaging with individual patients and in populations. We've got to do them simultaneously. Well, what's working from your perspective, and what are the bright lights?
Well, I just want to echo, I think your comment is spot on. There's no magic bullet. There's not a simple, single solution to address problems like homelessness or problems like food insecurity. The key feature here is really getting close to patients and hearing from them and engaging from them and understanding the very personal challenge that they face. This is also the challenge that we all face when we're trying to come up with a more holistic solution that builds on a number of different interventions to try to create sort of a surround sound approach to manage a population. There is enough heterogeneity in our population that what we learn isn't necessarily applicable to Ohio or isn't necessarily applicable to Idaho. What I can tell you is that we've learned a lot in over the last couple of years, and we expect to learn a lot more as this long-term support services program rolls out. But we've done a pretty rigorous study looking at the ability at what happens when you provide housing to very vulnerable, high-risk patients. And we've shown, and we've published the results, we've shown that cost savings outweigh the cost of providing the house, or providing the housing. There was a recent paper, it was from Boston and Health Affairs, looking at the opportunity to provide food to food insecure patients as a way to reduce total health care costs and improve their health. It was compelling. But there's a lot of these studies that are all focused on very specific populations. And what we got to do is somehow get this evidence into something that can be more digestible and generalizable so that we can all think about how to leverage that evidence in a thoughtful way across broader populations. And I think that's where the magic's going to happen.
Right. That's a great segue, and I want, Hal, your sort of sense of bright lights, but I want you to come back to the statement you made earlier about one of your sort of principles was interoperability of solutions, and that really speaks to the thing we want to take this, and where a number of the questions, and we love your questions, I'm trying to internalize them as we go along, but it's this notion about how to integrate with other social services, because I think what Cece was getting at in a couple of her questions in the panel previously was, whose job really is this, right? And I mean, seriously, we're going to do poverty? That's a part of this, and it's the case that each of the actors represented here may not have to do it by themselves, but do it in partnership. That's really the theme.
Well, I think one just quick thing is I think most health plans want to be able to do poverty. I think this idea that CMS suddenly is signaling that we're going to be able to invest in interventions to improve social determinants it's not a burden, it's a real opportunity.
Great. Well said.
Yeah, so Great question, and I would say this. In as much as I spent my 3 minutes first talking about personalized health or precision health, however you want to look at it, I remind myself constantly that all good ships rise with the tide. You just can't fix the ship, so to speak. You have to rise the tide if you really want to have the full benefit. And that's really by having initiatives in the community. For a company with 50 million members that's global, you could argue that's maybe more challenging than the life I had before, which is a large regional health system where we could plant a community garden or start a farmer's market or do those kinds of things or start a bike race or a marathon. So at Aetna, I'm gonna try to shed some light on the question.
A little ambiance.
Yeah, well, I'll keep on going until the candles get broken out. So at Aetna, we've done a few things that really try to do this at scale. No particular order. One is, most recently, we announced our Aetna U.S. News and World Report Healthiest Communities ranking. Why did we do this? Because what we wanted to do was showcase literally the healthiest communities in the country and identify what were the things that they were doing so that others could learn from that. Because there is good data that demonstrates what are the ingredients for success in those communities. Through partnerships that have come out of that, we've been able to promote healthy produce, for example, for over 250,000 individuals, almost 250,000 individuals. Another initiative through our Aetna Foundation has been our Healthiest Cities and Counties Challenge, where we've invested money in those communities, made seed investments to address a number of different things. So for example, in Dutchess County and Poughkeepsie, New York, we've created a partnership for a microgreens project. In New Haven, Connecticut, an asthma alliance. In Tulsa, a Healthy Cities Coalition to fight food deserts. In Ingram City, Michigan, a smoke-free home initiative. Again, is that going to solve every community's problem across the country? No, but these are investments that demonstrate how you can have a very significant impact in a community, and then the opportunity is to showcase it, and by showcasing it, you can scale it. And that's the strategy that we think, given our footprint being not only in the US, but even globally, how we can best do that using investments in these communities.
Right. Can any of you speak to your belief or interest and work with anchor institutions as a concept? This notion that, and this is where I think health systems like yours, Akram, come in, where you may be, the big dog in your community, and therefore you can bring your balance sheet to bear, you can bring your sort of civic connectedness to bear. Not necessarily that you're going to do all of it, and similarly, employers could be anchor institutions in their community. And I'm hearing a lot of, certainly from the health systems who are taking up the mantle of social determinants, using their heft in a local community to make a difference. Any of you want to speak to that sort of notion?
So MetroHealth last year borrowed $1 billion, issued $1 billion of bonds to redevelop our campus. And we decided to utilize that to improve the community around us. And specifically, we have just been informed that we are the only hospital system in the world to try to create an eco-district. An eco-district deals with poverty, education, housing, all the different things that you're talking about. So we've already have transportation strategy in which we improved public transportation throughout our area. We are creating housing across the board, from low-income housing to having our employees in the neighborhoods working. We have an incubator. We are turning our 52 acres right now of a concrete jungle, 25 acres where that will be green space, and we're actually creating an 8-acre park for the community that welcomes the community, and one that will be completely utilized on a day-to-day basis. So utilizing our heft, we actually created and around our zip codes, opportunity zones. We just got designated for that. We have millions of dollars of investments. We're working with LISC, with Local Initiative Support Corporation, to bring hundreds of millions of dollars of support for dealing with underlying issues around education, transportation, poverty, workforce development, and the like. And we see that as a once-in-a-life opportunity for us to utilize all these dollars to execute on these things. And that's where really, I think, if we're going to tackle poverty, we're going to tackle poverty by having all these groups of people focus on a single place and solving it one after another. And the reason we want to do it is because we would like other anchor institutions to see us doing it while we're still producing very positive operating results. Last year, 2017, MetroHealth ended up at nearly 4% operating margin, even with a mix that is 50% Medicaid and uninsured.
Yeah, that's remarkable. Martin, say a little bit about the employer's role in this, because the anchor institution doesn't have to be a healthcare system. I mean, you're playing very much that role in a lot of your communities, are you not?
We are. We, as a company, we spend 5% of our pre-tax income on community causes, and those are typically organized around children. It's healthcare, it's education, and other similar sorts of opportunities to give back to our communities. Additionally, we're the top, on top of the 5%, we're the top organization in terms of hunger relief efforts in the form of food banks, food bank donations in our state. And that's a big deal, I think. It sets an example. I think it helps communities, and it's very important. I think at the same time, to your question about what can we do as a large organization, and I'm not sure the best way to go at this would be how do we convene a collaborative effort across all of the healthcare sectors, which typically we fight, for our share of the pie, right. Be it our, pharmacy business, or be it as a payer, or be it, hospitals or the others. And it strikes me that there are things that we cannot do alone if our shared goal is to address access and quality outcomes and reduction of cost. And it strikes me there's value in convening a collaborative effort across sectors focused on understanding the details of the process, which is where the magic always is, of patient care. And I don't know the best way to go at that. It's one of the reasons I'm here, is to sort through how might that happen, because I think it's only by doing that we address the most fundamental issue in terms of helping to address poverty and education, which is taking the cost out of the system.
Right. No, well said. And that actually is a good segue. There have been a number of questions about sort of various measures and whether or not that we can integrate social determinants into the sort of quality metrics and so forth. But it's part of what Will raised earlier, this notion of evaluation on an ongoing basis. So let me ask you to say a little bit about where you think we're headed next, but also how we're going to manage this process to actually make it actionable. Because there's a danger this becomes, I call it the scout badge problem in American healthcare. You go to board retreats of hospitals and you say to them, are you doing value-based? Yes, we are. It's like the scouts, when you got we merit badge. Do you have an accountable care organization? I have 3 of them, right? Are you doing a diabetic registry? Yes, I am. Are you doing social determinants of health? Absolutely. Big, shiny gold one. Okay, what % of your patients get that on a routine basis? The square root of 0, okay? So we've got to get beyond the scout badge problem. So, I mean, how do we take what is clear interest, motivation because of risk, and the reasons Martin talked about, promising programs, how do we build a system that scales this across this community of stakeholders? Who wants to start? How?
So I think it's really about aligning the engagement with the solutions and then with the shared risk, but having the data to demonstrate a starting point and a goal. And to do that, you have to do it individual by individual, and you have to do it for the entire community. Without that information, it becomes impossible really to develop the glide paths for those systems, however they're constructed, and they're going to be in different communities. As you heard earlier, there are going to be different ways to do this. In some communities, it's like our joint venture partnerships with Inova or Allina or Sutter or any of those large health systems, where we basically go 50-50 with them and put them in the health insurance business. And in other communities where you don't have an integrated delivery system like that, it's working with various stakeholders and using data and information and logistics to put that together, because those are the best resources that are available at that time in that community.
Right. Well,
So I think we're, I think in general, the current administration is really pulling back on this idea of more and more measures. And there's a lot of burnout, and there's a lot of folks that find too many measures to be burdensome. My sense is that the opportunity here is all around aligning a mission with something that has an ROI. We as payers, providers, we desperately want to help our patients, our members, where they are. We know that they're struggling in ways that absolutely, unquestionably impact their health. And if we had strategies and resources and approaches to be able to help them deliver, get them to where they can actually participate in a reasonable healthcare plan, we all want to be there. My sense is it's not today about coming up with a whole bunch of different quality indicators and measures. My sense is let's throw a lot of stuff at the wall. Let's test things and try to really understand where it works, who it works on, how we can best organize these programs. These programs should make business sense and be aligned with our mission. The measures can come.
right, that's well said, right. So it's sort of try it, test it, fix it in your local geography with a sensitivity to the community. Uh-huh.
One of the questions that frequently comes up is, how do you pay for all this stuff, right? And I think that goes back to what I was describing in the beginning of this session, which is, if a third of the healthcare dollar goes to total waste, what are the barriers to repurposing that waste in ways that we can invest in social and behavioral determinants of health? I would argue that the ROI is enormous if we do it well. I think it does support jobs, and I think it really creates an economy. It's really about repurposing waste, and if you look again at how we compare it to other OECD nations, we have this huge opportunity to do it at a community level, to do it at an individual level, because frankly, I think looking for one single national solution like in smaller Northern European countries is just not realistic for the U.S. And this celebrates, I think, our ideals and goals in this country.
Right. No, well said. So what are some of the barriers that we need to knock down? And I'm thinking here, are there federal policy barriers or state policy barriers that are preventing things from happening? Are there data needs? Are there infrastructure questions? Are there new actors? I mean, what's preventing us from realizing the kind of vision you guys have described here?
So data is a big one.
Yeah.
It's an area that we're investing heavily in at UPMC, but still our ability to integrate our data with retail pharmacy or with urgent care or with retail clinics, our ability to collect all that information to be able to get a much more holistic sense of who our patients are, where they're getting their care. Ideally, we'd love to get data from other sources if it was, patients approved and were comfortable with it, so we could start to really, really better understand where the challenges are and how we can help them.
Just one data point. You were mentioning data. I was at the Hospital Association of Southern California a couple of weeks ago, and there was a young ER physician from UCSF presenting her data on California adopted, like Washington State had done, a sort of thin layer ER communication tool on top of electronic health records. So it basically allows ERs to know frequent flyers, essentially. And she showed some fascinating data amongst heavy utilizers, which basically showed that the typical heavy utilizer was going to 3 times the number of emergency room visits compared to the home institution. When you actually see, and it's, this is not all gaming to get opioids, right? I mean, this is just because people have lives that are challenging and end up with a lot of problems, homelessness, blah, 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 right? I mean, so to your point on data, we really, very few people have a 180-degree or 360-degree view of where the patient's experience really is. And it's meeting them in their lives, we're agreeing, is very important. We should find out more about that. So that's one. So what else needs to be knocked down in terms of barriers?
Well, I would say is, so you look at Hal's statement, and you cannot want a chief medical officer to say any more about tackling these problems than Hal did, of an insurance company, to say these things. However, that does not translate into action at significantly lower levels. So there's constant friction between insurance companies and the espoused need to deal with population health and improve the social determinants, and health systems espoused goals to deal with population health. It takes such a long time to even take tiny steps forward. It's got to get easier for us to do that. It takes enormous will, effort, and commitment to bring two parties who have a lot in common, which is an insurance company and a provider, to bring them together. If we're going to do this with five companies together, it's just got to get a lot easier. No one wants to share data. It is my data, you're going to use it against me, back and forth. So we've just decided we're going to act as if everyone is good at the table, and everybody wants to do the right thing. And I will tell you is that we've been wrong more times than right, but in the right times, we really achieved some significant breakthroughs. So I've sat with insurance executives.
That's great. Hal, you want to jump in here, and maybe one of you can follow up on this question, because I think it's on this point we were just talking about. How do you bridge the gap when both payers and systems want to lead population health initiatives? It really speaks to, it reminds me a little bit about the early stages of value, and before that, the early stages of quality improvement. Everybody had their own little wrinkle to it, and who's in charge in what is a multi-stakeholder problem, right? Hal?
Yeah, so I would say two things. In my former life as a health system CEO, one of the hardest things that we had to do was live in two worlds at the same time. We took full risk for roughly 76,000 lives in our community, and then everything else was fee-for-service. It is so difficult to try to do both simultaneously. And I think that, there's lots of conversations about value-based care and about risk, and a lot of it is upside risk. But if we're really going to be effective in moving towards the types of opportunities that we spent, almost an hour talking about here, we have to move away from fee-for-service. We have to move to value. And there has to be this ecosystem of shared risk among all the participants. And the second thing I would identify as a barrier, Ian, is the lack of interoperability. This enormous complexity of information management in the system, the silos that it sits in, and for whatever reason, we can't, as a health system in the US, move to true interoperability and transparency of health information that is actionable by patients and by every participant in the health ecosystem. You look at things like clinician burnout in this country. So much of that can be ascribed to information handling, dealing with the complexity of these new systems that we keep on laying on hospitals, on doctors, on nurses, and other providers in the ecosystem. And that's not what they signed up for. But it creates huge frustration, and I would argue even waste. These are two things that really need to be solved to allow us to move in the direction that I think everybody agrees we should be moving in.
Right. Well, I think that's a great place to bring us to our conclusion here. We've got a few minutes left. I'd love to give each of you a minute or so to really say, if we were reconvening this panel 5 years from now, what's the most important thing you hope will have happened with regard to social determinants of health and the opportunity we have in front of us really over the next 5 years? Martin, why don't you start?
What I would hope would be that we achieve what some of these guys have said, which is that we get to a level of collaboration, a level of data sharing, and an alignment around the outcomes. And to me, that's the answer to the question around how do you bridge the gap when both payers and systems want to lead these initiatives. It's got to start with an aligned set of outcomes. And I think if we can get to that point, which I think is pretty straightforward, then we make great progress. And so my hope for 5 years from now would be we're at that level, and that we find ways to convene all of the interested parties in a room together and start working through the details of the processes that need to be improved.
And just to reinforce, in your role as employer, when you wear your employer hat, you can bring a lot of energy to that conversation because you control the margin in the healthcare delivery system. Everybody recognizes that. And so it's a voice that needs to be in that conversation, right?
Yes.
Yeah. Akram?
So today, despite our enormous, what seems to be enormous efforts on focused on population health and social determinants, MetroHealth spends less than $10 million a year specifically on dealing with that. We're a $1.2 billion health system, so that's less than 1%. 5 years from now, I'd actually like that to be around 10%. Because that is when we will actually see some significant return on investments and sustainable change in our communities. So I would like to see this become a core part of our business, not just a way to survive.
I agree completely with what you just said. I think the vision for over the next couple of years would be that a movement towards greater risk runs hand in hand with experimentation and learning and improvement around how to actually help meet people where they are. And if we do that well, I am convinced wholeheartedly that we will get very good return on investment on these interventions. They'll be aligned with our mission. We're going to deliver better care at lower cost for our members. We'll see deeper collaboration between payers, providers, pharmacies, folks in the community that have the opportunity to make a difference. And social determinants of health won't be its own domain. It'll just be part of the fabric of how we manage our members.
And I think underlying what you each said is we ought to build a business case for this as we go along and make sure that there is a inherent rate of return going to come from this, that we're going in not to legislate it, but to create it as a movement. Hal?
Yeah, so I would say in 5 years, it would be terrific if we had a short list of proven initiatives that reflect social determinants of health, that have an ROI, that employers and communities, governmental agencies, nonprofits, hospitals, health systems, all can engage in together, create alliances in communities to leverage those, to make those investments, and then to see that return. But that requires not just the healthcare side of the equation doing that, that requires the employers and government in those communities as well. And if you could do that effectively and keep on reproducing it from community to community, I truly believe that you start to see the tide rise.
Right. No, I think that sort of brings out many of the themes we were hoping to unpack in this hour, was really this notion that there is a growing commitment of every stakeholder in the system and a recognition that going at it the way we're going, which is simply trying to do more, isn't going to work and is going to bankrupt us on the one hand and prevent us from making the investments, Martin, that you said at the beginning of this virtuous cycle we could be on of lower healthcare costs, more investment in our communities, higher incomes and higher attainment and better behavior as patients because we're not struggling with some of those issues. So there's a burning platform, I think we all agree. The notion that risk is increasing and value is increasing in the system, even if we are taking stuttering steps. You know, I'm an advisor to Levitt Partners, and Governor Levitt would say we're on a 40-year journey and we're only 25 years in. But it's pretty clear we have got to get on that alignment track of value and risk being shared and aligned across the system. And that we have to build an infrastructure to take social determinants from a rounding error, right? to being a mainstream way we do what we do. And all of you, I think, articulated that beautifully. And the final thing, I think, is the notion of leadership and commitment here, that this is a moment in the American health system where we can take advantage of interest and momentum and actually do something. And I think that was the spirit in which this panel was convened in this meeting, to really encourage people to take action, not just go to meetings and share PowerPoint with each other. Although that's my business, I love doing that. I think we can move somewhat beyond that to actually getting things done. Please join me in thanking our distinguished panel.